ITP is friendly fire. It's your immune system mistaking your own platelets for enemies. It produces IgG antibodies against the platelet surface protein like GP2B and 3A. It marks these guys for destruction in the spleen. So what's the result? You get isolated thrombocytopenia. It's like, all right, destruction, and with these symptoms also with bruising and petechia and also heavy menstrual bleeding. But there's no anemia. There's no schistocytes. So you could contrast this to like your TTP with the Adams TS13 deficiency, and that causes the activation of the von Willebrand factor to run wild and activation of platelets, and then that causes red blood cell damage, and you see schistocytes. But here in ITP, you see no schistocytes, right? It's just going to be abnormal coagulation test, right? It's a bleeding disorder, not a clotting one. And so the treatments are different. You use steroids, not like plasma exchange, for instance. So a 28-year-old woman has petechia and menorrhagia, and platelet count are super duper low, and hemoglobin, white blood cells, coagulation is normal, no recent infections. What is the most likely cause? This is going to be classic immunocytopenia, isolated low platelets, that's it, bleeding symptoms, and normal other labs. Okay, so that's pretty much all there is for this little practice question. The key features of ITP we kind of went over, but IgG antibodies. Platelets are opsonized. They're cleared by the splenic macrophages. Isolated thrombocytopenia, there's no anemia, no schistocytes. Bleeding signs, so you have the petechia, the bruising, the mucosa bleeds. Normal PT and normal PTT, and it's triggered by viral illness. If this was helpful, like and subscribe. We'll see you in the next video.